Hi, this is Forrest Calland. I'm a trauma surgeon at the University of Virginia, and on behalf of my collaborators here at UVA, the Trauma Center, I want to thank you for your time and attention. We're going to talk a little bit today about the treatment of tension pneumothorax in the pre-hospital environment in patients with traumatic injuries. Over the last several years, we have come to appreciate the fact that decompression of the chest in severe trauma is of great potential benefit, but very often doesn't help the patient or causes harm. More often than not over the last decade, the needle thoracostomies that we've seen at the University of Virginia have been found in the subcutaneous tissues of the patient, the musculature of the chest wall, including the pectoralis, within the lung parenchyma itself, or in the bronchi, rather than in a position that could have decompressed a tension pneumothorax. Most troubling is the fact that many of these interventions were performed in patients who really could not reasonably have been expected to have a tension pneumothorax prior to the intervention because they lacked the signs or symptoms of shock and or respiratory distress. With this module, we hope to provide you with some guidance and to help providers make better decisions regarding when to use needle decompression and the optimal techniques for doing so to avoid unnecessary harm. Looking at the data from our registry from the last 5 years, you can see on this slide that we've seen a steep increase in the utilization of needle thoracostomy over the last several years. Of the 29 cases we have recorded over the last 5 years, approximately 1 out of 6 needle thoracostomy procedures never made it into the thoracic cavity, likely related to the increasing body mass index of our regional, state, and national population. An additional 2 of these interventions clearly resulted in harm to the patients in which they were initiated, with one of these needles being put into the bronchus of the lung and an additional one placed into the lung parenchyma itself, causing a pneumothorax. Approximately 25% of the patients who received this intervention, or more, clearly had no indication to have it performed, as stated previously because of an absence of shock, hypoxia, and or alteration in mental status. In presenting the previous statistics, I do not want to in any way minimize the great care provided by pre-hospital providers in our region and elsewhere, nor give the impression that blunt or penetrating chest trauma is a benign condition that requires something other than appropriate and thoughtful intervention in order to save lives. Having acknowledged that, less than 25% of patients who make it to the hospital alive with penetrating chest trauma require anything more than a chest tube for definitive care. That said, nearly all of them require urgent decompression of the chest or placement of a chest tube within the first hour of care in the hospital to drain air or blood from the pleural space. In blunt chest trauma, respiratory failure is derived from the altered mechanics of the chest wall and diaphragm, from broken ribs, flail segments, and pain-limited ventilation. Making matters worse, most of these patients will have associated pulmonary contusions that impede gas exchange and produce hypoxia, and in some cases, even hypercapnia, neither of which serve to improve patients' mental status and nearly always make head injuries worse by starving the injured brain of oxygen. As alluded to in the preceding slide, there are a number of injuries that must be considered in patients with blunt and penetrating chest trauma. These injuries include not only damage to the ribs, lungs, and tracheobronchial tree, but also can affect the heart through direct bruising of the myocardium itself, so-called myocardial contusion. In addition to this, we sometimes observe impaired filling of the heart due to tamponade or catastrophic hemorrhage from aortic injuries, and even more rarely, injuries to the esophagus. In this figure, you can see a pneumothorax demonstrated in this patient's left lung, the one on the right side of the figure. In this picture, the lung tissue is pink and the pleural space is purple. In this patient's left thorax, the lung is collapsed and not well ventilated because air has been allowed to collect outside of it within the thoracic cavity, but outside the lung, so-called simple pneumothorax, which definitely does not require treatment in the field with needle decompression, and can even wait until it's definitively diagnosed with a chest X-ray when the patient arrives in the trauma bay. When air exits injured lung or enters the thorax from the environment due to the negative pressure in the chest caused by excursion of the diaphragm, at first the lung will be merely deflated against the mediastinum. Shortly thereafter, the pressure building up of air outside the lung will actually shift the mediastinum towards the other side of the chest and deform the vena cava, which can almost completely prevent blood return to the heart from the body. And the combination of these things causes critical shortness of breath, circulatory collapse, and altered mental status. This phenomenon is most commonly seen in penetrating chest trauma, but will occasionally occur in blunt chest trauma as well, and requires needle thoracostomy in the field when it does occur. To reiterate, only patients with tension pneumothorax, usually from a penetrating mechanism of injury, with respiratory failure and signs of shock such as hypotension, tachycardia, and altered mental status, need treatment of their tension pneumothorax in the field. An additional patient population that is highly susceptible to tension pneumothorax are those patients undergoing mechanical ventilation with an endotracheal tube in place and high PEEP or inspiratory pressures on a ventilator or a bag valve mask. This scenario is, of course, uncommon in pre-hospital care. Given the fact that it is hard to make an agonal or moribund patient worse with a medical intervention, we definitely encourage providers to perform bilateral chest decompression with needle thoracostomy in patients with traumatic cardiac arrest, particularly witnessed traumatic arrest, when the provider is sure that the patient's condition comes from their injuries and not an underlying medical event that preceded their injury. Indications that the patient is suffering from respiratory and/or circulatory collapse from tension pneumothorax include the visualization of penetrating chest wounds, altered mental status, panic, a sense of impending doom in the patient, and in unconscious patients, perhaps a sudden drop in the end tidal CO2 or tracheal deviation. To state this one more time, tracheal deviation is rarely observed and is a very late sign that usually is accompanied by cardiac arrest. The indications for performing needle thoracostomy in the field include witnessed traumatic arrest or near arrest in a patient who presents with bradycardia and agonal breathing. Other patients that may benefit from this procedure include those with respiratory, circulatory, and neurologic failure, as indicated or demonstrated by altered mental status with signs of shock in a patient with an appropriate mechanism of injury. The optimal location of insertion for needle decompression has recently changed from the second intercostal space in the midclavicular line to the fourth or fifth intercostal space just in front of the mid-axillary line. In this figure, right between the ovals marked B and C. In males, this location is just below and lateral to the nipple line. In females with pendulous breasts, on the other hand, it is lateral and 1 finger breadth inferior to the inframammary fold, which is portrayed in this figure as a curved red line. You should use a 14 or 16 gauge catheter to perform this procedure that is approximately 8 centimeters or 3.25 inches in length. Again, just anterior to the mid-axillary line. We wholeheartedly recommend that you verify your ability to identify this place with your training officer at your agency until you are completely comfortable doing so in the dark in a patient who is hard to access before performing this in the field. In order to ensure that this procedure is performed with appropriate patient selection and technique, we generally recommend that those performing this procedure have been actively practicing as an EMT-I or paramedic for the last 2 years. In addition, we recommend that every agency with providers who intend to perform this technique participate in annual or biannual training to assure competency. At the risk of overstatement, I want to reiterate that multiple indications that your patient is about to die are necessary prior to performing this procedure in the field. Simply appreciating diminished lung sounds, which are often hard to appreciate at a noisy scene or in the back of a diesel ambulance, is not even close to an adequate reason to decompress the chest with a long angiocath. When the finding of diminished breath sounds is accompanied by a combination of tachycardia, hypotension, and altered mental status, we want you to first consider the more likely possibility that the patient is bleeding prior to thinking about needle decompression of the chest. One of the major differences in patients who have tension pneumothorax as opposed to bleeding will be the presence of distended neck veins, which will almost always be flat in a patient with hemorrhagic shock. Again, hemorrhagic shock is at least 100 times more likely than tension pneumothorax in a severely injured patient with respiratory and circulatory failure. For the training officers out there, we want you looking at every single case of needle thoracostomy performed by providers at your institution to discern whether or not it was done with appropriate patient selection and technique. Providers should look for and receive feedback in every case in which this technique was applied, or in those cases where it probably should have been applied because of the presence of pre-hospital respiratory and circulatory collapse. We encourage you to collaborate with your receiving hospitals to get feedback on the imaging that is performed in the trauma bay in these patients so that providers may know in real time whether or not they made the right decision in applying or withholding this technique. At the University of Virginia, we are happy to provide this feedback to all of our regional operational medical directors and training officers on an ongoing basis. I want to thank all of you for your time and attention in listening to this important presentation. In front of you now are some useful references that we use to assemble this white paper.
This mannequin, we're going to blow it up. You most likely won't hear the swish of air because on the mannequin we have to actually use a 20 gauge needle, and this is a Gelco, and we use a 20 gauge Gelco because we don't want to destroy the bladder in the patient and in the mannequin. On a real patient, again, you're not going to use a 20 gauge, you're going to use a 10 or a 16 gauge, 18 gauge on pediatric patients. We want to make sure we're performing the right procedure, that this can be very dangerous if we are performing this procedure on a patient who does not need it. Somebody who's speaking to you in full sentences. Somebody you suspect may have a pneumothorax but not a tension pneumothorax. They have two different medical conditions. So I'm going to go ahead and I'm going to open the package up. I would don gloves. I would clean the area with alcohol prior to insertion. I would confirm that my patient truly is in extremis and having a severe tension pneumothorax event. I will open up the catheter. I will make sure I have some tape prepared so that I can secure it to the patient. And I'm going to actually place myself just a little bit more to the side. I am going to palpate my area, which is right here. We're going to blow up my balloon one more time. And then we are going to make sure we've cleaned it. I've got gloves. For demonstration, I won't wear gloves. Again, I'm going to palpate that area. There it is, the 50 intercostal space right there. And I'm going to insert my needle. Now, normally I would hear a whoosh of air. I'm going to secure this with tape. I'm going to take my needle, make sure it's in the sharps container so no one else gets stuck. And we're going to make sure that we transport the patient to the hospital. This is something that is going to be very rare in most EMS agencies' careers.